Welcome to Pediatric Sleep Disordered Breathing. This lecture is based on Chapter 22 in Walsh. Sleep may be defined as a neurophysically distinct state of awareness that is required for human health. It involves both developmental, physical, homeostatic, and behavioral factors. The function of sleep in mammals is not well understood. However, sleep deprivation can cause serious neurocognitive deficits and is lethal in animals. The association of disordered sleep and daytime function has long been appreciated. In fact, Sir William Osler stated that chronic enlargement of the tissues of the tonsillar ring is an affection of great importance and may influence in an extraordinary way the mental and bodily development of children. At night, the child's sleep is greatly disturbed. The respirations are loud and snorting, and there are sometimes prolonged pauses followed by deep, noisy inspirations. The neurodevelopmental and cognitive consequences of disturbed sleep in childhood are now an area of intense study and research. Normal sleep patterns. Sleep patterns progressively change throughout a child's life. A normal newborn spends approximately 70% of a 24-hour day sleeping. That is 16 to 18 hours of sleep a day. The baby typically has 3 to 4 hour periods of sleep interspersed with 1 to 2 hour awake periods all throughout the 24 hours. In the first few months of life, babies have not yet become fully trained to a day-night cycle, but a circadian rhythm consolidates about the 8th week or 2 months. Critical sleep reorganization occurs between 8 and 12 weeks. Sleep differentiates into non-rapid eye movement sleep or non-REM sleep and then rapid eye movement sleep. At 6 months, total sleep time is 13 to 14 hours and sleep episodes are 6 to 8 hours in length. Whew! I'm sure a lot of parents are happy about that. 70% of infants are sleeping through the night by 9 months. A toddler's total sleep time decreases further to about 12 to 14 hours, and the sleep cycle length is about 60 minutes, which means they cycle between REM and non-REM sleep. Daytime sleep decreases, so less napping throughout the first year. By the time the child is preschool aged, the sleep cycle has lengthened from 1 hour to 90 minutes, and the total sleep time has shortened to 11 to 12 hours. Daytime sleep continues to diminish, and most have given up napping by 4 to 5 years of age. The sleep pattern in school-aged children becomes much more stable, and sleep time continues to decrease. In fact, by the time they are 10 years old, children sleep 8 to 10 hours a night. Disordered breathing in infants and children. Respiration is under both voluntary and involuntary control. There has been a dramatic increase in our understanding of anatomic, neurochemical, and the genetic basis for the control of the rhythm of respiration. Respiratory control matures as the brain matures. This puts premature infants and young infants at increased risk for problems with breathing. Classical models of control of respiration describe central chemoreceptors in the medulla oblongata of the brainstem and peripheral chemoreceptors along the carotid body in the arch of the aorta. The central chemoreceptors respond to pH and carbon dioxide. On the other hand, the peripheral chemoreceptors respond to oxygen levels, or hypoxia. These models are currently undergoing modification because new evidence has been emerging. Infants have respiratory instability and very commonly have brief periods of apnea up to 10 seconds. These pauses are typically related to REM, rapid eye movement sleep. Periodic breathing is a breathing pattern also common in infants and can be defined as a pattern of cycles of rapid breathing followed by pauses longer than 3 seconds. Each cycle can occur 2 to 3 times a minute. Brief apneas and periodic breathing decrease in frequency with increasing age. Apnea. Apnea is defined as a respiratory pause sustained for more than 15 to 20 seconds, or 10 seconds if it's associated with a drop in heart rate, cyanosis, or a drop in oxygen saturation levels. Central sleep apnea. Central sleep apnea occurs when respiratory effort ceases. There is no chest movement and no airflow. Diagnosis of central apnea must take into account many different factors. Because infants normally have more rapid respirations, a normal respiratory rate of 40 a minute, and a reduced respiratory reserve, there is less protection from hypoxia. So shorter central events can be clinically significant in small infants. Central apnea can lead to significant physiologic compromise, such as a drop in heart rate, a bluish color to the skin, and dropping oxygen saturations. A number of anatomic and physiologic features of small babies those under a month old, put them at risk for sleep disordered breathing. Infants are near obligate nose breathers. Nasal obstruction may paradoxically lead to central apnea in neonates or contribute to respiratory obstruction and lead to obstructive apnea. The shape of the chest is more rounded, the diaphragm tends to be flatter, and the ribs tend to have less of an angle and are much more flexible. Since the rib cage contributes less to overall breathing in older children, chest wall compliance is very, very high. Unlike older children and adults whose FRC, or functional residual capacity, is maintained passively by a stiffer chest wall and chest wall recoil, the FRC in neonates has to be maintained actively because their ribs are so flexible. FRC is further decreased during REM due to lack of muscle tone. Apnea of prematurity. Apnea of prematurity is observed in infants born prematurely and is common among infants younger than 32 weeks. The pathophysiology of apnea of prematurity is not fully understood. It's assumed to be either central or obstructive, but they're not sure. Because of the unstable chest wall and immature lungs, nasal CPAP is often the first therapy used. If the infant continues to have apnea of prematurity, it may be related to the immaturity of the connections in the brain. and of the cardiorespiratory system, often in conjunction with environmental stimuli, which seems to be the basis of AOP. Apnea of prematurity is often treated with caffeine, which is thought to stimulate the respiratory centers. Caffeine can be given in either an oral or through a feeding tube or by IV. It has less side effects than other drugs. Sudden infant death syndrome, or SIDS, is a devastating event that accounted for over 2,000 infant deaths in 2009. By 2018, 1,300 of the sudden unexpected infant deaths were caused by SIDS. It is the leading cause of death in the first year of life and the third leading cause of infant death overall in the United States. Sudden and unexpected death of an infant for which sufficient cause cannot be found by a death scene investigation, a review of the history, or a postmortem is said to be sudden infant death. SIDS almost always takes place when an infant is presumed to have been asleep, either during the day or at night. However, almost 70% of SIDS victims are found in the early morning hours after sleeping all night. The incidence for SIDS peaks in infants 2 to 4 months of age, and this period coincides with significant changes occurring in sleep organization and in the brain. SIDS is uncommon after 6 months of age, with 90% of victims affected in the first 6 months of life. In fact, it's very rare after the 1 year of age to die from SIDS. There have been many theories that have been offered up to explain the tragedy of SIDS. Because it is assumed that there must be a cessation of breathing, there has been a focus on apnea as a precipitating event. The apnea hypothesis has driven SIDS research for about 40 years. In the 1980s, there was a search for a predictive model of SIDS, of who would get SIDS and who wouldn't, but that was unsuccessful. They studied abnormalities in cardiac rhythm, control of breathing, autonomic dysfunction, and faulty sleep arousal. However, it's been suggested that the occurrence of SIDS may not require an infant that's susceptible or at risk, but rather a consequence of normal neonatal development and physiology placed in the proper environmental context. There is now general agreement that the cause of SIDS has many different factors associated with it. Although a mechanical explanation of the cause has been elusive at best, there's significant progress in the prevention of SIDS, such as making sure that the baby is on their back, or the back to bed program. In 1994, the Back to Sleep campaign was initiated in the United States. This picture shows the incidence of SID and the age in months. You can see that the incidence of SIDS is at its highest between ages of right around 2 months of old, and it drops off significantly until 1 year. In fact, there's very little cases of SIDS after 6 months old. So let's talk about a few modifiable risk factors for SIDS. There are many different risk factors, both epidemiologic and modifiable, that are associated with SIDS. The modifiable ones are ones that we can do something about. So things that have contributed to a baby that they think dying of SIDS are things like babies put to bed on their belly, exposure in utero to opioids or cocaine, mother having anemia during pregnancy, inadequate prenatal care, bottle feeding and bottle propping, soft bed covers left in the baby's bed or loose bedding, overheating, sharing a bed with parents, and again, sleeping on the belly. All of these we can change. Some of the epidemiologic risk factors include being male, being African American, having a teenage mother, being premature, being born in the winter season, and having a low weight at birth. The Back to Bed campaign was first initiated again in 1994. The movement to aggressively encourage back sleeping has led to a dramatic decrease in the incidence of SIDS worldwide. An acute life-threatening event, or ALTI, is defined as an episode that is both frightening to the observer and characterized by some combination of apnea, color change, marked change in muscle tone or being limp, choking, or gagging. The ALTI may be idiopathic, meaning that we don't know what caused it, or can have an underlying cause. On physical examination, you should search for dysmorphic features, abnormality of the upper airway, chest, and cardiovascular system, as well as measuring the child and comparing it to norms. The phenomena of an ALTI is often related to SIDS. However, this relationship is poorly understood and increasingly controversial. In fact, the vast majority of infants who die from SIDS did not have a witnessed episode of apnea until the actual terminal event. Parental concern may make getting an accurate account of the event difficult at presentation, but with a credible story, especially in the presence of cyanosis or drop in heart rate, or with a resuscitation effort, an admission to the hospital is warranted. Evaluation has to include a thorough history, including family and social history. An accurate description of the event is vital, and a full review of systems and thorough physical examination should help to narrow the very extensive differential diagnosis for ALTI. The physical examination should carefully look for bruising and should include a full neurologic exam, including muscle tone and fundoscopic examination. The physical exam should also include a search for dysmorphic features and abnormalities of the upper airway, chest, and cardiovascular system. Basic measurements of the head, the body, the length, and the blood pressure should be made and compared with normal. Parental concern should be assessed and sensitively addressed. The extent of the workup will be determined by this admission data. A heightened index of suspicion must be maintained throughout because of an identifiable cause is found in nearly half the cases. In 2016, the Academy of Pediatrics released new guidelines for episodes that were previously defined as ULTIs. A brief, resolved, unexplained event, or BRUI, is defined as an event occurring in an infant less than 1 year of age that is sudden, brief, and now resolved in one or more of the following: cyanosis or pallor, absent, decreased, or irregular breathing, a marked change in tone, either hypertonia or hypotonia, being limp, and altered level of responsiveness. This diagnosis is made when there is no explanation for the qualifying event after conducting an appropriate history and physical examination. The goal of this change in nomenclature was to outline more precise diagnostic criteria, stratification into lower risk versus higher risk patients, or ones that should be admitted to the hospitals and ones that may not need to be. And the usage of terminology that is less anxiety producing. The term ULTI, previously called near-miss SIDS, is broad and with non-specific symptoms, leading to potentially unnecessary investigations and hospitalizations. There is no clear association between an ULTI, a BRUI, and SIDS. The lower risk BRUI patients are older than 60 days of age, have a gestational age of 32 weeks or greater, and a post-conceptual age of 45 weeks or greater. They have no previous BRUI. There is no cardiopulmonary resuscitation or CPR required, and there was no concerning history. No potential abuse, no family history of SIDS or sudden death, and no CPS reporting. And there were no concerning physical examination findings, no bruising, nothing like that. Home monitoring for apnea in infants at risk remains a controversial subject. In the 1980s and 1990s, the prevailing sentiment was that home monitoring made sense because some patients who had apnea requiring resuscitation subsequently had a recurrence of the life-threatening event. Furthermore, a small number of patients subsequently died of SIDS. Some centers have had a home monitoring program in place for many, many years and remain committed to monitoring high-risk infants. These include babies who have had a sibling die of SIDS, premature babies who are known to have significant apnea, and infants who have had an ULTI. Recently, the efficacy of this practice has been called into question. In an editorial accompanying the Collaborative Home Infant Monitoring Evaluation, or CHIMI, study, it was stated that the physiologic basis for such monitoring is more in doubt than ever. The CHIMI study did not support the idea that babies who are thought to be at increased risk of SIDS have more cardiorespiratory events than other babies. The Association of American Perinatologists has recommended that home monitoring should not be used as a strategy to prevent SIDS. It is likely that monitoring will continue in some babies. However, this will be done on an individual basis. And when the risk and may benefit when caretakers are appropriately trained and compliant in its use. Caretakers in this situation should also be trained in infant CPR as well. Obstructive sleep apnea, or OSA. Obstructive sleep apnea is a breathing disorder that occurs in sleep and is characterized by repeated, complete or partial obstruction of the upper airway such that gas exchange or sleep integrity is compromised. Multiple factors influence airway patency, including the way the airway is shaped, anatomic structures around the upper airway, control of laryngeal muscles, cardiorespiratory control, and neuromuscular control. Because obstruction does not occur when your patient is awake, it's apparent that anatomic features alone are not sufficient to explain OSA. The major cause of OSA in children without any other predisposing condition is adenotonsillar hypertrophy, or big, floppy, oversized tonsils. Anatomic restriction in the airway by the tonsils in combination with altered laryngeal muscle control results in obstruction of the airway. OSA is common in children and its occurrence ranges from 1.2% to 5.7% in children without a predisposing condition. In children with a predisposing condition, the prevalence can be considerably greater. It may occur in children of all ages, but the prevalence peaks between 2 and 8 years of age, which coincides with the time when the tonsils are big and the upper airway is small. The variable changes in upper airway resistance and caliber lead to a continuum of clinical syndromes which range from primary snoring to frank intermittent occlusion of the upper airway. Primary snoring may affect as many as 10% of children, but is not typically associated with disturbance of sleep architecture or gas exchange. Upper airway resistance syndrome, or UARS, is characterized by recurrent respiratory effort-related arousals during sleep. These episodes are not typically associated with gas exchange abnormalities, but they can be associated with significant daytime symptoms. Obstructive hypopneas may occur in absence of complete obstruction of the airway and cessation of airflow. These sleep-related events lead to disruption of sleep architecture, degradation of sleep quality, and gas exchange abnormalities that can cause significant daytime sleepiness. If unrecognized and untreated, upper airway obstructions are a considerable threat to a child's health. We've known for a long time that chronic obstruction is associated with substantial morbidity. It became clear in the 1980s and 1990s that childhood OSA was distinct from adult OSA. Features that distinguish childhood OSA are that the child may be normal or even underweight. They may have continuous snoring. They may have a pattern of hypopneas and upper airway restriction syndrome. It's very common to have enlarged tonsils. It's common to have the most hypopneas and apneas in REM sleep. Insulin resistance is absent. There are infrequent problems with the heart, and there are behavioral and neurocognitive as well as bedwetting. that may, again, include poor school performance and hyperactivity. This is a nasal CPAP in a micropreemie infant. The most common physical findings are limited to the upper airway. The most common finding in a child with OSA is big tonsils. Other findings that can be important are mouth breathing, a very small chin or micronapthia, a retronapthia or a chin that tends to be pushed back, a crowded oropharynx, a highly arched, narrow palate, nasal mucosal edema, nasal septal deviation, and nasal malocclusion. Body weight is also important. Obesity is a known risk factor for sleep-disordered breathing. So how do we tell if a kid has OSA, central sleep apnea, or sleep disordered breathing? We need to do an overnight polysomnography. Laboratory assessment of breathing and sleep includes an overnight polysomnography or PSG. Pediatric PSG parameters differ in many respects from adult ones. Things that may be monitored in a child include EEG, to include 3 to 6 channels, electroocular, so eyes, heart, oxygen saturation, airflow via either pressure or a thermistor, end tidal CO2, a peak and a waveform, a snore mic, measure of respiratory effort with chest and abdominal belts, measure of muscle activity, including a chin and a leg EMG, video and audio recording, timestamp video, and body position sensor. You can see a child here getting ready to have a sleep study. To comprehensively assess the adequacy of ventilation and differentiate between central and obstructive sleep apnea, we should use chest and belly belts to look at the chest and wall and abdominal movement, as well as an airflow sensor at the nose and mouth, transcutaneous oxygen saturation for small infants, and end tidal CO2 for larger ones. Capnography is a graphic representation of EtCO2 and is recommended because it can assess both airflow and ventilation at the same time. A standard PSG also includes additional parameters that can provide important information, like an ECG. ECG monitors cardiac rate and rhythm and is useful in evaluating consequences to the heart of sleep-disordered breathing. A PSG may include EMG of the anterior tibialis muscles to identify periodic limb movement or kicking of the legs during sleep, which can be supportive of a diagnosis of periodic limb movement. However, this disorder is rare in infants and children. It's more common in adults. And we don't monitor it unless it's clinically indicated, unless the parents have observed the kicking. Laboratory should be supervised with a sleep specialist trained for working with children and should have a child-friendly setting with child-friendly equipment. Laboratory assessment is essential. The definitive study to assess sleep is the polysomnogram. A diagnostic PSG is performed in an accredited sleep laboratory by trained personnel. Sleep stage is determined by using a standard EEG montage that includes bilateral EOG and 6 EEG leads. Tibial and facial muscle activity is recorded by EMG. In addition, the complete PSG includes nasal airflow, chest and abdominal wall plasmography, ETCO2, video and audio recording, snore volume body position sensor, ECG, and oxygen saturation. Sleep stage scoring allows for quantification of sleep architecture. An EMG arousal may not be perceived by the patient as an awakening, but may still result in disruption of sleep architecture and daytime sleepiness or sleep symptoms. Complications include many medical conditions are associated with increased risk. Conditions that have decreased oropharyngeal space as a feature include craniopharyngeal syndromes, Down syndrome, mucopolysaccharide storage disease, and Prader-Willi syndrome. Patients with neurologic disease, most notably Chiari malformation, may be at increased risk for sleep-disordered breathing, and patients with neuromuscular disease may have an increased incidence of sleep-disordered breathing. These patients are less likely to be cured with a tonsillectomy alone. They may require other surgical procedures, Chiari malformation decompression, or mandibular distraction, or the jaw being broken and brought forward. Or treatment with CPAP or bilevel. Bilevel is positive airway pressure, or BiPAP, or even a tracheostomy, depending on the severity of the sleep-related gas exchange abnormalities. So here's a picture of a patient in a laboratory having an overnight polysomnogram. You can see that the respiratory therapist and sleep technologist is quite happy. They've hooked the patient up to everything possible and now want him to sleep. Last but not least, home cardiorespiratory monitors. Again, these are only for a select group of patients. They alert the caregiver to an apneic or cardiac event. They are diagnostic devices. They need people that have these devices at home need extensive training, including infant CPR, and social and parental implications for this should be considered. The parents need to be a care provider needs to be a stable person that can undergo the training and understand it and be around. This may include aunties, grandmas, parents. So that's it. Thank you so much for listening to this, and I will see you later.